Happy New Year to many of you in the audience who celebrate the Chinese Lunar New Year like I do. So welcome and best wishes for good health and prosperity in 2020 in the year of the rat. Good evening. Just to introduce myself, I'm Helen Hayward with Sunnybrook's Board of Directors, and it's my pleasure to welcome you all to this evening's lecture series. Tonight's topic is one many of you were asking for more information on our hands. Did you know that the hand has 27 bones, or that each finger has 3 bones? Thumbs only have 2, and they are no less important, as we all know, working with every finger to let us perform both complex and delicate tasks. Hands are incredibly designed tools that allow us to get things done and even reach out to others. We know the importance of washing our hands, but they're also something to be protected. All too often, hands are cut, crushed, scraped, burned, or affected by repetitive motions. Because we use them in immeasurable ways every single day, it's important to keep in mind how their functions are becoming impaired, including through illness and injury, and how to mitigate these risks. Here at Sunnybrook, we're fortunate to have a wealth of experts who oversee everything from injury prevention and arthritis care to surgical and treatment options for hand injuries that can cause pain and impair functioning. We will be hearing from many of them in just a moment. If you haven't already, please consider signing up to the speaker series mailing list. You can do so online or in the evaluation forms that are placed on your chairs this evening. You can also check out the Sunnybrook website for details on upcoming speaker series dates and topics for 2020. So to get tonight's event started, I'd like to now introduce our moderator, Dr. Larry Robinson. If you are a speaker series regular, you might recognize Dr. Robinson, as he has been a huge supporter and contributor to these talks over the years. Dr. Robinson is Program Chief of Rehabilitation Services at St. John's Rehab. He has written more than 100 articles and peer-reviewed publications and has authored books on the subject of rehabilitation. In addition, Dr. Robinson is a physiatrist. I almost misread it as psychiatrist, but it's...
Attention please, code blue, B, Bravo Wing, 5th floor, ICU, bed 3. Attention please, code blue, B, Bravo Wing, 5th floor, ICU, bed 3.
So Dr. Robinson is a physiatrist, pardon me, and a senior scientist involved in several research projects. We're very fortunate to have him here this evening to not only lead us through the talks, but to also present on the topic of nerve injuries. Please join me in giving him a warm welcome.
Thank you very much, Helen, and welcome to everyone, and to those on online, and Xinyan Hao to those celebrating the Chinese New Year. So tonight our lecture is called Within Reach, Common Hand Issues and Helpful Solutions. I'll start off the talks tonight with a presentation on nerve injuries, which are not that uncommon. They are fairly common. Then Dr. Sharron Sandhu will talk about managing arthritis in your hands. Tiffany Chow, one of our occupational therapists, will present on preventive and adaptive strategies for healthy hands. And then our colleague, Dr. Paul Binhammer, will give an overview of surgical options for hand issues. Now, we'll set aside some time at the end of the session to answer questions, and we'll ask you to fill out, there's some small white blank cards on your seats, to fill those out. And if you have a question, hold it up and one of our volunteers will come by and get it, and then we'll answer those at the end. Now, if you need to get up during the evening, feel free to get up. We haven't really timed in a scheduled break, so if you need to go out to the washroom, that's totally fine. They're just outside the auditorium, and there's still, I think, some refreshments in back there. So to begin, I want to talk about nerve injuries. So there's a little cartoon here. I hear you need a carpool urgently. No, I need carpal tunnel surgery. The repetitive motion of typing has caused permanent damage. I have to wear braces until the surgery. Well, there's no room in my carpool. So I'm sure many of you have heard about carpal tunnel syndrome. We'll talk about what it is. I won't cover the surgical management because Dr. Binhammer will cover that. And I won't cover very much the preventive strategies and the work ergonomics because Tiffany Chow will be covering that. So the two things we'll talk about are carpal tunnel syndrome and ulnar neuropathy. Those are the two most common nerve injuries that we get in our hands, in our upper limbs. Talk about the symptoms, that is, what do people experience when they get carpal tunnel syndrome? We'll talk about the risk factors. What's going to be likely to give you carpal tunnel syndrome?
Your attention please, your attention please. Cancel, cold blue, B, rebel wing, 5th floor, bed 3. Your attention please, your attention please. Cancel, cold blue, B, rebel wing, 5th floor, bed 3.
We'll talk about the mechanism of injury. Why do you get these nerve injuries? How you do the testing, and then a little bit about treatment. So carpal tunnel syndrome is the most common nerve injury we'll get in our hands. The carpal tunnel syndrome is compression of the median nerve, which the median nerve supplies this part of the hand in blue here. More on the palm side than on the back side, but it comes back a little bit to the back of the fingers. But mostly it's the palm side of the hand, more the thumb side. And when people get carpal tunnel syndrome, they get numbness and tingling predominantly in this kind of distribution where the blue is. Now, I wish people would know and they'd study up and figure out where they're supposed to have numbness and tingling, but it usually doesn't work that way. They say my whole hand is numb, or they say just 3 of my fingers or 2 of my fingers are numb. So it doesn't always work out to the way we think it should based on where the nerve supplies sensation. But that is what people most commonly report as numbness and tingling in their hands. They may have wrist and hand pain along with it, and they may have a sensation of swelling. It feels like your hand is swollen. If you look at the person's hand, it won't necessarily appear swollen, but it feels that way. Just like when you go to the dentist and you get a Novocaine injection and your jaw feels huge, same thing here in your hand. You have numbness and tingling in your hand. It feels bigger. People will also report that their hand is weak and clumsy. They'll say that they drop things frequently because part of that is the weakness and part of that the lack of sensory feedback. And often people will have what we call a flick sign. So usually what we'll say is, do you get numbness and tingling wakes you up at night? They say, yeah, I get that. But what do you do? And they go like this. They flick their hand back and forth. And that's a common thing that we'll see in people with carpal tunnel syndrome. Don't really know why they do it. It obviously gives them some relief, but that's a common thing. And it's usually worse in the middle of the night when you're sleeping, wakes people up at night. It's usually worse with driving. And it's usually worse when you're doing manual labor. So someone who's on an assembly line or like the chicken processing plant or using their hands all day, that will often make the symptoms worse. What are the risk factors? In other words, who gets carpal tunnel syndrome? Tends to be women more than men, typically in that 40 to 60-year-old range. It's not exclusively in that range, and sometimes you get it coming on at later in age, sometimes earlier on, particularly the industrial ones. It's mostly light and medium duty industry, so it's people who are using high force and high repetition with their hands. So common industries would be chicken processing, the people who cut up the chickens to put in the package. Ski manufacturing is one that's been reported a lot. Grocery workers who are just constantly using their hands to move items back and forth. It's really related to the degree of force you're using every day and the number of repetitions. Those are the two big risk factors around industry. Obesity is also a risk factor. As we'll be talking about, carpal tunnel syndrome is due to compression of the median nerve at the wrist. And if you have more tissue at your wrist with related to obesity, you're more likely to get carpal tunnel syndrome. And it's in the range of a 3-fold risk factor, those who are obese versus those who are not. Pregnancy, particularly in the 3rd trimester, is a risk factor for carpal tunnel syndrome, but that usually gets better after delivery. Diabetes is a risk factor, and we believe that's because the nerves in diabetes are not normal. They tend to be sick nerves and more susceptible to compression at the wrist. And hypothyroidism is another risk factor if you have a low thyroid. And one I don't have on here is rheumatoid arthritis. Rheumatoid arthritis because there's so much extra tissue in the wrist that it ends up compressing the median nerve. So those are the people who are at highest risk. It's not just those folks, but it is these are the big ones. How do you get carpal tunnel syndrome? What's the mechanism? Well, it's a compression of the median nerve at the wrist. That's what's doing it. And we believe this gets compressed in large part because we get inflamed tendons. And also, as I'll show you in a moment, going through the wrist, there are 9 different tendons, 2 for each of the fingers and 1 for the thumb, as well as the median nerve. They're all going through a small space. And if those tendons get inflamed and swollen, they're going to be pressing on that median nerve. So as the tendons swell and get inflamed, they start pressing on the median nerve. And it's worse with bending the wrist, either bending it this way, which we call flexion, or extension. That puts more pressure on the nerve, and also with hand use. As you get compression on the nerve, you first affect the nerve insulation. So the nerve is kind of like a big telephone cable. You got the copper wires, which are what you call the axons in this case, and you got the insulation, like the rubber insulation, which we call the myelin in this case. With mild compression, you affect the myelin or the insulation first. And if compression gets worse, you'll actually lose some of the axons or the copper wires that are inside the wires. So that would be when it gets worse. You'd lose some of those nerve fibers. So this is a picture, and Dr. Binhammer is going to be much more eloquent than I am around the anatomy and the surgery. But this yellow thing over here, that's the median nerve. That's the guy that's supplying sensation to your fingers. It's coming up through here. It's splitting up into, splitting up into branches that go up and supply the fingers. It even supplies these muscles near the thumb. And then lying on top of that is this ligament, which we call the flexor retinaculum or the transverse carpal ligament. And this is where the median nerve gets compressed. This yellow guy gets compressed underneath this ligament that's holding down the nerve and these 9 tendons. And when that gets compressed, that's what gives you the numbness and the weakness and the clumsiness. This is another view as if you took a cross-section through the wrist. So not looking at it from the front, but if you had an imaginary cut and you cut through the wrist and looked at it through the end. So going through here are some of the bones, which are down in the bottom here. And in through this small space, this is where you have your 9 tendons. And then this one guy, the median nerve that's up top here. And they all have to live in this small space. If the tendons get bigger through overuse and inflammation, they take up more room. There really isn't any more room. So what gets squished is the median nerve. And that's what gives you the symptoms. And just one other view, this is what we call a sagittal view from the side. Here's one tendon, this white thing, and then its tendon sheath or synovium covers it. So that's there. There are actually 9 of them, even though we got one pictured here. This is with a hand palm down. Then the black thing is the median nerve. That's sitting right in there with the tendons. And then this pink thing is that ligament or the flexor retinaculum. And when everyone's healthy, then everything's good. The median nerve has plenty of room. But on the bottom, what happens if this tenosynovium gets inflamed? You're using your hands a lot, get inflammation of those tendons. They take up more space. I just got one showing here, but there's 9 of them. And they end up compressing, squishing that median nerve under the ligament. And that's why you get symptoms. Now, carpal tunnel syndrome is not the only cause of hand numbness or hand pain. There are other causes, and we have to work through the other potential causes so we know what we're treating. So cervical radiculopathy, which is the pinched nerve in the neck, that can cause hand numbness because if you interrupt the nerves up in the neck, you won't have the normal feeling down in your hand if you interrupt those nerves that supply the hand. Sometimes you don't have a compression in the nerve, but you just have inflammation of the tendons from overuse. So this tendinitis can present with pain in the hand and wrist. Usually wouldn't present with numbness because you don't have a nerve involved, but it would present with pain. You've probably seen people using vibrating tools. The construction workers out on the street who are using the jackhammer, there's a ton of vibrating tools out there in industry, and that can give you hand numbness and pain. And then a thing we call peripheral neuropathy, peripheral polyneuropathy. That's where all your nerves are not normal. So someone with diabetes, for example, all the nerves are affected, and you'll have numbness in your hands and numbness in your feet. The longest nerves are affected first, so it's those hands and feet that are affected first. And that can be a cause for hand pain and numbness. This is a little bit of a complicated slide, but I'll just walk you through it. This is the way we would do the testing. So we'll stimulate either the median nerve, the one that's involved, or the ulnar nerve, which is not involved, and we'll record from the ring finger. Now the ring finger is kind of special in that it gets two nerves supplying it. You might remember from the earlier slide that the median nerve supplies half of this finger, half of this ring finger. The other half is the ulnar nerve. So if you were to compare the two nerves, you could say, well, the median nerve is not working normally, the ulnar nerve is working okay, and that would start your thinking along the lines of carpal tunnel syndrome. And the way we do this is we stimulate the nerve at the wrist, record the electrical activity at the finger, and see how long it takes to go along that pathway. We measure the same distance for both nerves. And on the right here, we're measuring the nerve conduction. So going across this side to side is time, and up and down is voltage. This top one is the median nerve, and you can see the peak of that response is over here. We're going to measure that, and it took 3.8 milliseconds, or 3.8 thousandths of a second to go that distance. The ulnar nerve is quicker. It only took 3.2 milliseconds. So that tells us there's something wrong with the median nerve. We compare the median and the ulnar, and we say, that's funny, the median nerve is taking longer, even though it's the same distance. It must have some compression, and we think of that as damage to the myelin or the insulation. The thumb is also kind of special in that has two nerves supplying it, the median nerve for the palm side and the radial nerve for the back side. And we can do a similar comparison where you can see the peak to the median nerve is taking 3.2 milliseconds. The radial nerve for the same distance is 2.7. That difference in slowing would indicate that there's some compression of the median nerve. So we can sort out whether someone actually does have carpal tunnel syndrome or not by measuring how fast the median nerve conducts compared to other nerves. And the one below is another comparison between median and ulnar. So what are some of the treatment options? And my colleagues are going to go into this in much more detail, so I will just be very brief here. One option is ergonomics. Like, look at your workplace and figure out if there are things that you can do differently to avoid some of that overuse of the tendons, avoid abnormal wrist position. Can you do frequent breaks to maybe give your hands a chance to rest? That is one part of the treatment. And again, I'll defer to Tiffany. Splinting can also help. So what splinting does is it reduces the finger and tendon movement and swelling, reduces the wrist bending, and it may help at night and when you're resting by reducing some of that inflammation and the pressure on the nerve. It is honestly difficult to work in. You'll see people at the grocery store, they'll try to work in it the best they can, but it is really tough to get a good hard grip on things. It's tough to use during work. So mostly we recommend people wear it every night for 2 to 3 months. They're not real expensive. They're like in that $30, $40 range at Shoppers Home Health. You can just go buy one. But they are very effective for the mild carpal tunnel syndrome. This is just a study where they've looked at the pressures on the carpal tunnel at different wrist positions. So they look at neutral, which is your hand just straight, and then flexion, where you bend it to 90 degrees this way, or extension, where you bend it 90 degrees the other way. And they measure the pressure on the nerve. In control people, that is people who have no symptoms, your pressure on the nerve goes up from 5 millimeters of mercury, goes up 6-fold to 30 millimeters of mercury. So that flexion and extension seem to have a big impact on the pressure on the nerve. In carpal tunnel patients, they already start off high, 30 millimeters of mercury, and they go up to 90 millimeters of mercury with flexion or extension. So it appears that just keeping the wrist straight will offer quite a bit of benefit in reducing the pressure. There's also injection, and what we do here is we inject steroids into the carpal tunnel. The idea is to reduce the inflammation of those tendons. Remember, the tendons get swollen, and if we can reduce the inflammation, that will reduce the pressure on the nerve, and usually gives good relief for several months. Not necessarily a permanent solution, because if you go back and use your hand and the steroids wear off, again, you might get symptoms again. But it's a very good, useful measure for several months, and in some people it does give long-lasting relief. And then we don't inject it into the nerve per se. It's not that the nerve is inflamed. We want to inject it around the tendons so that we reduce the inflammation on the tendons, and then that reduces the pressure on the nerve. I'm going to defer to Dr. Binhammer on the surgery. It's basically cutting this ligament that I talked about that's holding everything down and putting pressure on the median nerve. That's a brief picture of someone cutting that structure. And then the results of decompression are generally good. Dr. Binhammer is much more articulate on this than I am. Half the people roughly, and it depends on the severity, will get complete relief or excellent results. Another 30% will get very good results, like 75% or better improvement. Then there's a few people who get minimal improvement, about 10%, and about 10% who don't get much change or who may even get a little bit worse. The great majority, though, do get improvement after the surgery, and it's not a big surgery. People will mostly return to work after carpal tunnel syndrome, most of the time, but not all the time, to the same job. It depends how strenuous your job is. And the factors associated with a poor likelihood of return to work are, if you're a workers' compensation case, it means you probably got a job that's tough on your hands. If you have repetitive hand motions, that's a tough risk factor. Using vibrating tools is going to be a problem. And physically strenuous preoperative work activity, if you're really doing a lot of strenuous activity at the job, that is a chance for less good return for work. I just want to talk more briefly about ulnar neuropathy at the elbow. That's the second most common nerve injury you'll see. The ulnar nerve, remember where the median nerve, it's supplied to 3.5 on the thumb, 3.5 digits. The ulnar nerve supplies the 1.5 fingers, so the little finger and half of the ring finger, both sides, the back and the front of the hand. That's where the ulnar nerve supplies sensation. So people who have ulnar neuropathy at the elbow, they have numbness and tingling and pain in that distribution, both the back and the front. They are pretty good at reading the anatomy book. They almost always come in and say, "Doc, I have numbness and tingling in these 2 fingers." They're more specific than the carpal tunnel patients for whatever reason. I don't really know why. They often have weakness of the hand. They'll have trouble holding small items. And sometimes it's worse when they're sleeping because their elbow is bent, and that puts a fair amount of stress on the ulnar nerve at the elbow. Or if they have pressure on the elbow, the people who are on the phone all day with their elbow resting on a desk. Or even just on a cell phone, when your hand is up like this, you've got your elbow bent all day. That's a risk factor for ulnar neuropathy. We can do a sign to look for a subtle weakness. What we do is we ask people to hold a piece of paper like this on the right, and that uses some of those muscles supplied by the ulnar nerve. When they have weakness, they can't actually do that. So they switch to other muscles, which is on the left. And they use different muscles. They can't do what we ask them to on the right. That's called a Froment sign. And I think it works better with a $20 bill than with a piece of paper. So the ulnar nerve comes down the arm here, goes right behind the elbow. This is your funny bone. You know, you've hit your funny bone. That's the ulnar nerve is what you've hit. And this is where it gets impinged, and it comes down and supplies muscles and sensation in the hand. I already showed you the sensory distribution over here. And we believe that it gets most compressed right at the elbow. So this is a picture of the elbow from the side. The nerve is coming down from the shoulder. It's coming down through this bony groove, goes underneath a muscle over here, and then supplies the 1.5 fingers and the hand muscles. And this is where it gets impinged, as it's going through this bony groove over here. There are multiple places there where it can get compressed. You can have it from just external pressure on the elbow. So again, if you're put pressure on it, if you have a motor vehicle crash or other injury, that can cause an injury to the nerve. You can have, if you have a fracture or arthritis at the elbow, that can cause pressure. So there's bony abnormalities there. As you saw in the previous slide, it goes underneath this muscle right here, the flexor carpi ulnaris, and it can get compressed over there. There's multiple places around the elbow where it can compress. In some people, it's about 15%. The nerve doesn't stay here. It doesn't stay where we think it should. About 15%, the nerve actually slips back and forth across this bony prominence. And it's what we call subluxation. We can often feel it. You feel the nerve as you bend the elbow, and you can feel it slipping in and out. And those people might be at higher risk for ulnar nerve problems. Bent elbows is a risk for ulnar neuropathy over the long term. This guy, the stony guy, had no hand strength. If I stayed like that for a long time, I wouldn't have any hand strength either. What we do is we measure this velocity of the nerve as it goes across the elbow, and that's how we find slowing. This is a picture of recording responses from the hand muscles as we work our way up the nerve. And these first two, as we're working up the nerve, are normal. But as we get around the elbow, we start to get a smaller response. It takes longer to get there. And again, as we work our way up, it gets smaller and smaller. So we can get down to within a centimeter or two of where the ulnar nerve problem is. And that helps us to define what the injury is, and also helps us to sort out what the next steps in treatment are. There are some conservative treatments, and again, I'll defer to Tiffany Chow on these. The conservative treatment can be helpful in the more mild cases. Simple things like avoid pressure over the nerve, avoid resting your elbow on a desk or a table. Think about the armrest in your car. If your elbow is resting right on the armrest, those are potential risk factors. And avoid prolonged elbow flexion, keeping your elbow bent like this for prolonged periods. That is a risk factor. So holding your phone up during your ear. Some people sleep with their arms like this, and that creates symptoms. They wake up in the middle of the night with their fingers numb. Some people will use, to prevent that, a towel or an elbow pad around their elbow. And sometimes what we recommend doing is getting one of those hockey elbow pads. Don't put the pad in the back, but put it in front. And the reason there is because then that prevents you from bending your elbow during sleep. You don't really know what you're doing with your elbow during sleep, so that helps. Surgery, again, I'll defer to Dr. Binhammer, but that is helpful for, especially for the more severe cases or those who don't respond to these conservative treatments. And there are multiple approaches which vary from just freeing up the nerve from its surrounding tissues to taking off that piece of bone that's right in front of there, to moving the nerve to the front of the elbow from the back so it doesn't have to go around that corner. And sometimes they can even do, there are some new nerve transfers which are really exciting, to take nerve fibers from a different nerve and plug it into the ulnar nerve, and that's very useful in more severe cases. So just to summarize, because I know my time's coming up, we reviewed symptoms of the two most common nerve injuries in the upper limbs, carpal tunnel syndrome and ulnar neuropathy. Nerve testing can help us determine the precise cause and the site of the injury. And there are some conservative things we can all do to treat those nerve problems or prevent them from getting worse. And you'll hear more about some of these conservative treatments coming up. And surgical interventions can be very helpful in some cases, particularly the ones where the conservative treatment is not helpful. So thank you for your attention. One more risk factor, don't get arrested and handcuffed, because that is another risk for getting a nerve injury. So thank you. Next, and one more reminder I'm supposed to remember, if you have a question, write it down in your card and we'll collect it later on. We have volunteers standing by, ready to collect your cards. Next, I'd like to introduce our next presenter, Dr. Sharron Sandhu. Dr. Sandhu is a staff rheumatologist and has a special clinical interest in the management of rheumatic diseases in pregnancy. So we're very happy to have her here this evening to talk about managing arthritis in your hands. Please join me in giving Dr. Sandhu a warm welcome.
Somebody else's water. Thank you for the introduction, Larry. So my name is Sharron Sandhu, and I'm staff rheumatologist here at Sunnybrook. And I'm going to be talking to you a little bit about managing arthritis in your hands. The first thing I want to talk about really is, well, what is arthritis? And the term arthritis doesn't actually denote one particular disease entity. It's more of an informal way of grouping diseases of the joints. And there are really well over 100 types of arthritis. And I have 10 to 15 minutes today, so we're not going to be covering these individually, except that I will be spending a little bit more time on osteoarthritis, which is the commonest type of arthritis affecting the hands. And generally, when we're thinking about arthritis in any joint, really, we're thinking about whether this is a degenerative type of arthritis, where there's less by way of inflammation, and the commonest type of arthritis in that is really osteoarthritis, versus whether this might be an inflammatory arthritis, where there might be either an autoimmune component, like if it was something like rheumatoid arthritis, or an arthritis associated with lupus or other types of seronegative diseases, or if this might be a crystal type of arthritis. What sort of symptoms might you get with arthritis? Well, by and large, most people will describe pain and stiffness, and to varying degrees there may be swelling in the joints. And once the disease becomes established, then you sometimes have limitations in terms of range of motion and also physical impairment in some cases. Depending on what sort of arthritis there is, there may also be signs or clues outside the joints in their skin or in their eyes or other organs as well. So what's osteoarthritis? Well, osteoarthritis is the commonest type of arthritis, and really the issue in osteoarthritis is really one that occurs at the level of the cartilage. So what happens is that the cartilage which cushions the end of your bones, at the joints especially, starts to break down. And once it starts to break down, then it gradually degrades over time, and eventually you get bone rubbing against the bone. And this gives rise to the symptoms: the stiffness, the pain, the loss of movement in some cases, and also swelling. So this is a picture of somebody who has osteoarthritis of the hands. And the typical involvement when someone has osteoarthritis of the hands, I'm sorry, I don't have a pointer, so I'm going to use my fingers, but often they get swelling and discomfort at the base of their thumbs, and also involvement at what we call the proximal interphalangeal joints, so these knuckles here, and the distal or the end knuckles as well. I'm sure you've all heard of rheumatoid arthritis. So rheumatoid arthritis is really the commonest autoimmune inflammatory arthritis. It tends to affect about 1% of the population.
Our next speaker is Dr. Tiffany Chow, now being known as Tiffany Shea. Tiffany is an occupational therapist, and we're very pleased she's here to discuss preventive and adaptive strategies for healthy hands. Please give Tiffany a warm welcome this evening.
Thank you, Dr. Robertson, for that introduction. Hi, I'm Tiffany, and I'll be starting with a brief introduction and then getting into my topic, which is using strategies to prevent further hand impairment and maintaining function. There are three categories of strategies that I'll be discussing today: protection, such as ways to prevent hand injuries; using equipment or aids when working with your hands; and general management solutions that will help keep your hands healthy. So who am I? I'm an occupational therapist. I'm guessing some of you have heard of us occupational therapists, or for short, OTs, but not quite sure what we do. Understanding what occupational therapists do can help you understand my topic today and how it relates to common hand injuries. OTs are concerned about your day-to-day functioning, like what activities you engage in on a daily basis to feel like yourself. So for example, self-care tasks like bathing or shaving your face, maybe productivity tasks like the job demands you need to fulfill to bring in an income, or even leisure tasks like knitting or going for daily walks outside. It's these activities that we focus on. We call them activities of daily living. As OTs, our main focus is to help you complete daily activity living so you can have meaning and purpose in your life. So when we talk about having dysfunction in a critical part of our body, such as our hands, This significantly impacts our ability to complete our daily tasks. OTs can help use interventions such as education, splinting, skills retraining, and exercise to bring function back to your hands. I'm going to start off by talking about protective strategies. I'll give you some examples of how to protect your hands shortly, but first, why is protection so important? Adopting these strategies are important in preventing injuries such as cutting your finger or breaking your bones. As well, you should protect your hands to decrease wear and tear of your joints, decrease strain of your muscles and tendons, and to assist in decreasing pain that you may be feeling. The key idea is to incorporate these adaptive strategies as part of your lifestyle while you're doing your daily activities. Next, the big how. What are some ways to protect your hands and wrists? So get used to the idea of respecting pain. The most important thing is to refrain from doing any movements that give you excessive pain. If an activity gives you pain for more than an hour afterwards, that could indicate that the activity was too stressful on your joints and muscles. You can start tracking your pain in efforts to prevent it by creating a pain journal. I have an example of a journal on this slide. Some questions to ask or track are, what activities caused your pain? Around how long were you participating in the activity for? Maybe how long did the pain last? Of course, then asking yourself, what helped the pain? Maybe you can delegate the activity to someone else temporarily, or maybe you can do the activity differently. There's a general term that is repetitive strain injury. Many of our hand and arm ailments can be classified under repetitive strain injury. The term represents conditions brought on by repetitive movements or prolonged positional holds. Think about trigger finger, carpal tunnel syndrome, and even tennis elbow. If we engage in activities which require the same movements repetitively, our tendons, muscles, and joints may suffer some trauma that can result in inflammation. The key is to decrease repetitive movement. For example, when using the mouse on the computer, instead of using the same finger for mouse work, you can train your middle finger to offload and do some of the mouse clicking. As well, you want to avoid being in the same position for long periods of time. This is what it means by static hold. For example, holding the phone to your ear for a long duration. Try to switch hands or maybe invest in a headset to decrease the burden on your hand and your arm. Leading into the next strategy, take rest breaks. To break up repetitive movements or static holds, you should always plan a rest break during an activity. Plan your break before the point of exhaustion or before you feel severe pain to ensure that you're adequately preventing further injury. Avoid overpressure. Any tool or activity that requires you to use excessive force on your hands should be avoided. One way to ensure you reduce overpressure when you're gripping a tool is to find a tool that fits your hand grip. A good rule, as seen in the first picture, is that the tool should allow you to grip your thumb, to have your thumb slightly gripping over your second finger. If the tool is too small or too large, it requires you to exert more force to get the work done. If the tool is too small, you can build up the object, like in the second picture, where items like pencils, shavers, or fork and knives are built up with foam or plastic. Another way to reduce the amount of pressure or work your hands need to do is by using levers. Levers allow you to use your larger joints and muscles to reduce the force required from your small muscles in your hands and fingers. Try to use larger joints, as well, more than one joint when you're doing things. When you use larger joints, for example, the lady in the first picture, instead of using two hands to grip the grocery bags, you can use your elbows instead. As well, you can use two hands instead of one to lift heavy objects. When you're doing your everyday tasks, slow down. Rushing can cause accidents and often lead to mistakes. When doing something dangerous, use caution, not speed. Think about what you're doing before you're doing it. Using hammering as an example, don't hold the nail with your fingers. Use a needle nose plier, or as demonstrated in the photo, use a clothespin to hold it in place. If you're using a knife or any dangerous tool, for example, cutting an avocado, removing the pit, ensure that the knife is sharp because that's easier to control. Work with the blade away from your body and definitely no freestyling. Put the fruit down on the cutting board. Another reason to slow down is to prevent falling. Breaking your wrist due to a fall is actually one of the most common reasons that risk factors occur. Avoid awkward positions of your hands when you're working. In particular, be aware of the wrist angle. Try to keep your wrist angle the same as your work surface. Or an easier way of thinking about it is maintaining a straight wrist while working on a task, especially repetitive tasks. Avoid having the wrist bent upwards or downwards, as well as deviated to the right or the left. As Dr. Robinson talked about, we have many little bones in the base of our hands that make up the carpal tunnel, and when we have our wrist bent, pressure in the tunnel increases. When the pressure increases, our tendons, nerves running through become compressed, which may give rise to carpal tunnel syndrome. Referring to the top photo, the best position to use a keyboard is when the wrist is straight or in neutral. The same concept can be applied with choosing equipment. Ensure the grip handle promotes a neutral wrist where there is no bending, as seen in the bottom photos. Think about the posture of your back and shoulders when using your hands. There is a tight connection between our posture and upper extremity function. It's interesting when we think of our bodies, each part works in correspondence with another. For example, our back is connected to our shoulders and arms. So when our arm moves, our shoulder and back is affected. A good demonstration is, and try this with me, is if you sat very slouched and you try to raise your arms above your head, you don't go very far, you're restricted. But if you sat nice and straight and you brought your hands up, you can go much further. So generally speaking, when we want to use our hands for precision, like cutting or using tweezers or maybe writing, it works best when we're sitting with a straight posture with our shoulders pulled back. If we look at the ideal posture of the girl playing piano, she's sitting upright, shoulders pulled back, as well her elbows are closer to her side. This position allows her to more effectively play piano compared to her slumped position on the right. The next category is considering equipment and adaptive aids to use in your activities of daily living. Most of the equipment can be bought at local medical equipment stores. Equipment and adaptive aids can be used to protect and prevent further damage to your hands, such as wearing protective gloves. However, they must fit well. If the glove fits your hand properly, you're more likely to wear it while working. Poorly fitting gloves can actually increase the force required by the muscles to compensate for the loose or tight glove. Also, depending on what you're doing, you may want to look for some gloves that offer some friction or grip. As well, ask yourself, what am I doing? And what are the potential risks to your hands? Maybe you're using sharp tools or operating equipment that vibrates. Maybe you're working with extreme temperatures like hot or cold. There are also some gloves on the market that are geared for arthritis. They are thinner than protective gloves and offer slight compression to the hand. The gloves are meant to decrease pain, swelling, stiffness, and meant to be worn during the day with activity. There are mixed reviews on the effectiveness of this glove. However, I've had patients say that they've benefited from them. So if you do have severely arthritic hands, you may want to consider trying them. Arthritic or arthritis gloves. You can also consider wearing a splint. If you're under the care of a specialist or therapist, you can ask for their opinion first, because depending on your injuries, the splint you require will differ. Splints or orthotics can serve many purposes. They provide joint stability or allow certain joints and tendons to rest and recover. The splint does this by usually immobilizing the joints and tendons or by maintaining the hand in certain positions. Sometimes splints are also used to prevent and correct deformities in your hands. Usually these splints are prescribed from a doctor or occupational therapist, for example, post-surgery or even post-stroke. Splints can be prefabricated, meaning you can buy them at the store already made, or they can be made custom to fit your size and needs by an occupational therapist. Referring to the picture with the black wrist, similar to the one in Dr. Robinson's slide, this splint is usually meant for carpal tunnel syndrome as it keeps the wrist in neutral position. And as we know, once the wrist is straight, it allows more optimum space for the tendon and nerves to move. If you refer to the third picture, this splint provides stability to the knuckle of the base of the thumb, where arthritis commonly affects. The stability of the splint supports the joint with movement, ultimately helping reducing pain. On to the next category, strategies for general management. For general management, exercise is essential to maintaining hand mobility and strength. If you have a particular disorder, you want to consult with your physio or occupational therapist to assess you and give you a more individualized therapy plan. If you're feeling stiffness in your hands, a good way to maintain health and mobility of your hands is to move your wrist and hand as often as you can. You can easily engage in range of motion exercises when you're in front of the TV or maybe during your rest breaks during work. The first picture shows some simple finger movements called finger opposition, where your thumb is bent to touch each one of your fingers, forming an O. Alternate from your second finger to the pinky, and this is done in a sequence. If you want to train your coordination as well, you can add a little bit of speed. So when you're done with the pinky finger, you can reverse back to the thumb, adding more quickness. To warm up your wrists, you can do wrist circles, both clockwise, counterclockwise, as well as both up and down. You can also begin to do some exercises for the deeper muscles and tendons in your hands to stay limber. These hand positions are completed in sequence. You can start with your hands relaxed with fingers straight, then transition to a hook. You can do a duckbill, tabletop, and then lastly make a fist. That would be considered one cycle. If you find one position more difficult, you can hold it, or you can repeat the sequence from the straight fingers to the difficult position. You can also add stretches to your daily routine. Be gentle. The objective isn't to feel pain, rather to feel some tension. You can hold the stretch for at least 30 seconds if tolerated. For example, if you have trigger finger and your finger tends to bend downwards, you can place your hand on the table, gently lift the finger upwards to feel a bit of a stretch and releasing that tendon that's been stuck. Before you think about strengthening, you should not be experiencing pain, redness, or swelling in your hand because strengthening at the wrong time can worsen your symptoms. Since we have so many small muscle and joints in our hands, some of the equipment we use to strengthen can be everyday objects around the house. For example, practicing your grip, you can use a small size stress ball or even a rolled up towel. Referring to the second picture, you can strengthen your pitch with some putty by manipulating it. You can also purchase something called TheraPutty, which offers different resistances. The last picture depicts using an elastic band to strengthen our hand muscles that help with opening our grasp. If you're feeling very stiff and need some help to start the exercises, you can try putting your hands into warm water or wrapping a hot pack around the affected area for about 8 to 10 minutes. Heat can help relax your tight muscles prior to exercise, making it easier to begin movement and strengthening. Cold therapy or using cold packs can help if you're having a flare-up, like acute swelling, redness, and pain. Applying some cold to the affected area can help reduce the inflammation. Remember, with both hot and cold, don't place it directly on the skin. Wrap the pack around a towel. As well, if symptoms persist, you should see your family doctor. Lastly, I want to summarize the important points that I've touched upon today when talking about common hand injuries and managing them with lifestyle strategies. Remember, you can still do the things you love, just do them safely and perhaps differently. The key strategies to adopt into your lifestyle are avoiding movements that cause pain, using larger joints or more than one joint with activity, Take rest breaks to avoid repetitive movements. Think about your posture. Choose the proper work tools. Protect your hands with gloves or a splint. And lastly, exercise daily. Thank you very much for your attention.
Thank you, Tiffany. I loved all those hints. I especially like the one to hold the nail with a clothespin. I've hit my thumb so many times on nailing stuff. I'm going to do that when I go home now. So thank you. Again, if you have questions, hold them up and we'll come get them. Next we have our final speaker, last but not least at all, Dr. Paul Binhammer. Dr. Paul Binhammer is an expert hand surgeon. He has expertise in hand surgery, wrist surgery, and microvascular surgery. He and I have worked together over these last couple of years. It's amazing to see the nerve transfers and the nerve surgeries that he does on a microscopic level. So Dr. Binhammer is going to talk about surgery in the hand. Welcome, Dr. Binhammer.
Thank you, Larry. It's great to go at the end because all of your colleagues have done all the hard work, and I have their expertise, you now know, and I have so little to add. So some of this is repetitive, and so if there's parts that I don't explain or are missing, again, as Larry has said, please fill out cards and we'll try and fill in the gaps. So I'm going to talk about carpal tunnel, trigger finger, and osteoarthritis. And I'm not going to talk about everything else because everything else is the trauma work we do here at Sunnybrook. And I was told no scary pictures. So I'm going to stay away from the scary pictures. So carpal tunnel syndrome. So you've heard Larry talk about this, and I'm just going to emphasize a few points. So what do patients say when they come into the office? They come in, they say, I have numbness or tingling in my hand or fingers. It wakes me at night. It happens when I hold an object. Frequently people talk about books, hair dryers, steering wheels. I'll say I drop things. I've dropped glasses. They break and shatter. I've broken too many plates and my spouse is upset with me. I have to put my hand down at my side and I shake it out. You heard Larry talk about that flick sign that people will wake up with night. So that's those complaints that patients have with carpal tunnel syndrome. So what happens with carpal tunnel syndrome? So here you have that picture that Larry talked about the cross section of the hand. And this is the wrist. And in the back is the carpal bones. And these are the bones in the wrist. And you can feel them on the back of your hand, these lumps in the back. Well, running across those bones at the front is this white structure or ligament. It's attaching from one bone all the way to the other side. And because it's a tight fibrous structure, it's like canvas, it's really thick, it makes a tight tunnel. So the tunnel is made by the ligament and the bones in the back, and it's not expansile, doesn't move. And it's through that tunnel that goes the nerve, the median nerve, and 9 tendons. So they're all squishing through that space, and it's fixed, it can't expand. There's something else that goes in that space, and that's your red blood cells, which carry the oxygen. And they have to get into that space. And if the red blood cells and oxygen can't get into that space, then there's no oxygen to your nerve. Well, I think you can all appreciate that if you hold your breath, what happens to your brain? It stops functioning. Turn blue in the face, you pass out. Same thing happens to your nerve. It gets too tight in that space. The red blood cells, which are traveling through your body, can't get in there. There's no oxygen to your nerve stops working. I got numbness and tingling in my hand. I got to shake it out. So you shake it out, the red blood cells come back in, nerve gets the oxygen, you're happy. So for most patients, numbness and tingling comes and goes, and that's carpal tunnel syndrome. So we've heard from the team tonight the options for management, behavioral modification, use strategies that we've heard about, change what you do, Splinting and bracing, especially at night, can help put the wrist at rest. Try and get rid of the swelling. Try and let the oxygen come inside. Interesting. Steroid or cortisone injections can also provide some short-term relief, helping that swelling go down, but it tends to be only a temporary fix. And then there's surgery. So I'm not going to show you any scary pictures. I'm just going to tell you about it. Surgery is pretty simple, relatively. Some people think it's a big operation, but it's a simple operation. It's just like going to the dentist. You don't have to change your clothes. You don't have to do any special tests. It's just local anesthesia. So you've all had some local anesthesia for a cavity or something. Put some freezing in right here at your wrist. Make it go numb. You're still in your clothes. Make about a 2 centimeter or 1 inch incision through the skin down to that tight ligament, that piece of canvas, and you cut it. Once you've done that, that opens up the space. The tunnel is open at the top, the red blood cells can get in. Then you have to put about 4 sutures, stitches in the skin, and a Band-Aid dressing on, and that's the surgery. You get up from the dentist chair, you go home. So it's local anesthesia, 15 minutes. How long does it take to recover? Well, you can use your hand right away to feed yourself and get dressed. If you do a light job, like you work in an office, somewhere between 4 to 6 weeks, you're usually back at work. Some patients a little bit longer, some patients a little bit less. What about if you do something heavy? You're a bricklayer, you're a carpenter. Dr. Robinson talked about heavy repetitive jobs and getting carpal tunnel syndrome. So if you do a heavy repetitive job, it takes you usually 3 to 4 months to get back to pounding nails, lifting bricks. Not all patients do, but on average, that's about how long it takes you to recover from your carpal tunnel. This is probably the second most common condition hand surgeons see. It's called trigger finger. And if you're thinking about the NRA and Washington, D.C., it's not that type of trigger. So I'll see if I can get this video to run. So the trigger finger it's not always this bad. This is a bad trigger finger. And you can see this patient's ring finger is stuck down in his palm. It almost looks like he's holding it down there on purpose, but you're going to see it's not like that. Now just take your other hand and unlock it. Pop. Super. And bend it down again.
And lock it?
Yeah. You can bend your whole and straighten out your hand. That's it. And show us once more. Perfect. So that's trigger finger. So sometimes you don't have to use your other hand to straighten it out, but the finger comes, you make a fist, and you go to straighten out your fingers, and one of them doesn't want to. And then you go, pop, and then it does. So what's a trigger finger? Now just take. So just like the carpal tunnel is a tunnel where structures have to pass through, the tendon is the same thing for each of your fingers. And there's this tendon that starts, this tunnel that starts right about here and runs to the end of your fingers. And in that tunnel goes your tendons. So just like you can get swelling inside the carpal tunnel, you can get swelling within this tunnel in the finger, and you can get a lump or swelling or nodule. And here it is, the swelling on the tendon. And when you bend your finger down and the tendon glides down towards your forearm, that lump pops outside the tunnel. So now it's outside the tunnel, but it's kind of big. And now when you try and straighten out your finger, you got to get that lump back down that tunnel. So when you try and get that lump back out, down in the tunnel, That's when your finger clicks or triggers. It can be any finger and your thumb, but we trigger thumb, trigger finger, trigger digit. So what's the treatment? Well, we know a bunch of them. We're not really sure how many, but maybe as much as 30% of them, if a patient has it, it will go away on its own. So you can try rest, try a splint, watching it. We also know that if you have a cortisone injection, one injection has about a 70% chance of resolving your problem. It's not 100%, 70%. And you can repeat the cortisone injection. And so that cortisone is to shrink that swelling on the tendon, get the finger moving again. So cortisone isn't the answer to everything. So it doesn't always work. So you can also have surgery if the cortisone doesn't work. And it's half the operation as the carpal tunnel. So it takes about 7 minutes instead of 15 minutes. Again, you get to wear your clothes. So walk in with your clothes, put some local anesthesia in right here, make about a 1 centimeter incision, open the top of that tunnel right just at that one spot, 2 stitches in your skin, Band-Aid on, go home. Use your hand, come back, see the doc in about 10 days, have your stitches out. That operation works about 99% of the time. What about osteoarthritis? So we've had an excellent talk this evening by Dr. Sandhu, so there's not a lot for me to add. So you've heard this, my hands are stiff in the morning, hurts to pinch or grip, pain with activities, patients get swelling, weakness, pain. And then if it gets bad enough, some patients with osteoarthritis can complain of pain all the time. We saw a similar picture. This is the picture, and this shows the Heberden's nodes. And since somebody asked the question, do we do anything about Heberden's nodes surgically? The answer generally is no, unless you have really bad pain with them or you have instability, meaning my finger, instead of staying straight, goes off to the side. And that's when you've lost a lot of cartilage in the bone. And sometimes that's a functional problem because you go to pinch and your finger goes in the wrong direction and you can't hold anything. So if that's a problem, that you don't have that stability in that joint, then we can do something called a joint fusion or a joint arthrodesis, where we take 2 bones and make them 1 bone. So you still bend at the other joints in your finger, but that one that was going off to the side, giving you problems with your pinch, is now stable. So with the joint fusion, it's an excellent pain relieving operation. I would never say everything's 100%, but it's about a 90%. But this is actually the joint that gets more attention from hand surgeons than your IP or interphalangeal or finger knuckles. It's at the base of your thumb. And this is the most symptomatic joint that patients usually have. And it's where your metacarpal, that's this bone in your thumb, meets a bone underneath called your trapezium. And your trapezium got its name because it's shaped like a trapezium or square. And the 2 bones interact, and they have a really interesting joint. You might have seen a saddle sitting on a horse. That gives the rider lots of ways to move. They can move back and forth and move side to side. And that's actually the shape of this joint at the base of your thumb. And that's why when you take your thumb, you can make big circles around. It's that horseshoe saddle-shaped joint that's moving round and round. But it can become painful. And so patients can present complaining of pain, swelling of that joint. And you can use different means to manage that, like splints and steroid injections and analgesics, topical, etc. So we've already talked about the cause, so I'm not going to. We've talked about the treatment, things like behavior modification, adaptive devices, which we've heard an excellent talk about, supportive splints, medications, oral, topical, intra-articular. There's other things people do and try, and then there's surgery. And really the two options are either joint fusion or joint replacement. So I mentioned already joint fusion. So that's where you take two bones and make them one bone. And if you can afford to lose that motion, then it's a good operation. So we don't need a lot of motion at the very end of our fingers. So to have a joint fusion, you don't really notice the loss of function. Joint arthroplasty or joint replacement, you've probably heard of it, about it. It happens in hips and knees. People get their hips replaced and knees replaced. You can also get finger joints replaced. And you can also get thumb joints replaced. And the most common in the hand is the thumb joint at the base here. That's the most common joint replacement we do. And it has pretty good success rate. It's a longer operation than 15 minutes, and you, and you do have to get changed for it. So it's about a 50-minute operation. And it's day surgery, come in, have it done, go home, and you come back in about a week's time and you get changed over to a plastic splint. You can use your hands right away, but it takes patients a little bit longer than the simpler surgery. It takes patients around 6 weeks to 12 weeks to get over it. It does have an excellent success rate. It's been around a long time. It gives about 85% of patients good to excellent pain relief. So that's the end of my talk, and Larry's back up.
Thank you, Dr. Binhammer. And maybe don't sit down just yet, because we were going to ask our speakers to come up and have a seat up at the table, and we'll go through some of the questions. Thank you, all speakers, for your excellent talks. This was really elucidating, and I learned a lot myself as well. So we'll go through some of the questions, if that's okay. And I got questions for everyone. Please hold up your questions if you have some. Some of them were actually already answered. I had a number of questions on trigger finger, and so Paul, thank you for addressing trigger finger, because a lot of people were wondering about that. Let me start off with one for Tiffany. Can you use arthritic gloves at night? And if not, why not?
They're generally used for day use with activity. I haven't heard anyone using it at night, but definitely if you find it helpful and you've tried it, you wear it at nighttime, it offers you some pain relief, maybe gives you a little bit less stiffness in the morning, you could try using it. But they are marketed and meant for daytime use with activity. So using it day to day while you're doing things around the house, when you're at work.
Great. For Dr. Sandhu, a couple of medication questions. Actually, I have a number of medication questions. I'll just ask you a couple here. What about taking diclofenac? Is it bad for a person? What are the side effects? And same thing for Tylenol. Is that good for arthritis, and is there side effects?
Okay, so those are actually two excellent questions. Diclofenac, if for those of you who don't know, is a non-steroidal anti-inflammatory. And really about 10 years ago, we started to realize that generally all non-steroidal anti-inflammatories do have some other side effects in terms of, so we always knew about the fact that they sometimes cause ulcers in the gastric mucosa, and they can make kidney function worse, but there's also an increased cardiovascular risk. And so generally most of us prefer using ibuprofen or naproxen if you're taking anti-inflammatories longer term, because they are slightly better from a protection profile. Diclofenac is really helpful though in people who've got gout. We use stronger, more potent anti-inflammatories like diclofenac or indomethacin, but we use them for short periods just to help with the acute flare in the gout setting. In terms of your question about acetaminophen, again, you know, we tend to prefer for pain relief using acetaminophen-based preparations first before using regular anti-inflammatories. So if somebody needed chronic pain management, we'd start with acetaminophen first, adding the oral anti-inflammatory as needed. But for short periods of time during acute flares, anti-inflammatories can be very useful.
Great, thank you. Dr. Binhammer, can you talk about Dupuytren's contracture? What's the cause? What's the treatment?
So Dupuytren's, for those who are wondering or trying to understand, Dupuytren's is collagen fiber thickening found in the palm or digit. So often patients will present with a lump in the palm. It's a nodule, and that's usually the first presentation. And it may then sort of progress or start to go down a finger. And if it does progress, it doesn't progress in everybody, but if it does progress, then the collagen fibers may shorten and pull the finger down. And it's not like a trigger finger where you can pop it back out. This is a slow process of the collagen fibers pulling the finger down. And then we say they have a cord. So they not only have like a nodule, but they also have a cord. So who gets, we're not exactly sure why people get Dupuytren's. There's a large genetic component to it. It can run in families. It can be associated with trauma, but why an individual precisely gets it. It also tends to be more common in Northern Europeans than anybody else. And should I keep on going?
Please.
There's basically 3 forms of treatment for it. There's a small, even less than an operation, where you can use a sharp needle to break up the fibers. Think of the fibers as like in your pants or shirt, and if you punch a bunch of holes with a big needle, then you have a tear or a rip in your shirt. Well, that will tear or rip those collagen fibers to allow you to straighten out your finger. There's an injectable enzyme that will actually dissolve those collagen fibers. And it has a drug company makes it. It's called Xiaflex. There's only one available. It's not covered by the government. Some insurance companies cover it, but it actually dissolves the collagen fibers. And then there's finally surgery to cut it out. So you can either sort of break it up with a needle, you can dissolve it with an enzyme, or you can surgically remove it.
So the most important question is, of course, when you do it with a needle, you get to keep your clothes on.
Yes.
Okay, just wanted to clarify. So Tiffany, I think a number of people like those hand position exercises, and we're wondering how they can maybe get handouts like that. Not everyone has an internet connection, so are there other resources you would advise for learning about those exercises?
If you're connected with a therapist, you can always review the, I call them tendon glides for your hands. You can ask them about that so they can demonstrate it to you. Otherwise, you may want to check out some arthritic resources. There was a Arthritic Society outside. I'm not sure if they have any resources on exercises there. Certainly, if you guys are still here after the question, I can go through it with you as well.
Great, thank you. Dr. Sandhu, what is erosive osteoarthritis, and can it attack other joints in the body?
So erosive osteoarthritis is where you have osteoarthritis, but in addition to the cartilage getting damaged, there's also a little bit of damage into the bone. And it's associated typically with the type of osteoarthritis called nodal osteoarthritis. So it's where it affects the joints in the proximal interphalangeal joints here and in the distal interphalangeal joints. And sorry, Larry, what was the second part of the question?
Can it attack other joints in the body?
So you don't tend to get erosive osteoarthritis anywhere else in the body except in the hands.
Great. And is there a connection between, while you're on the microphone, between diabetes and arthritis?
So diabetes itself increases your risk of things like gout, for example. So people with metabolic syndrome and diabetes, hypertension, obesity, all sort of feed into the whole metabolic syndrome, does increase your risk of getting gout. And diabetes itself can also produce a form of arthritis where patients, well, it can cause a couple of things in the hands. So one of the other things is that it can cause tightness in the fingers so that you can't actually extend the fingers completely, and that's sometimes to do with the soft tissues around the fingers, but it can also be associated with arthritis sometimes.
Thank you. Dr. Binhammer, what would cause a thumb not to bend? And if it's moved in a certain direction, it's painful.
So there's a lot of different moving parts in the thumb, so it could be many things. It could be arthritis in a joint that prevents you from bending it. That's one, but you can also have a trigger thumb or trigger finger that stops you from bending it. So sometimes, and you saw the picture of the clicking finger, sometimes patients will have so much pain or so much swelling from that inflammation in the tendon that will stop them from bending their thumb as well.
And while you've got the microphone there, is there any limit as to how many steroid injections you can have on one joint?
So joint or tendon? So if we're talking about tendon for trigger finger, there sort of is an unwritten rule of 3, but there has been published work that has shown patients have gotten up to 5 and not had any obvious adverse effects to it.
And I have a question for my talk. Is tennis elbow a form of ulnar neuropathy? Is it temporary if you stop lifting heavy things? So tennis elbow is another problem with the elbow, but it's actually on the other side of the elbow. The ulnar neuropathy is on the inside part here where the nerve goes through the ulnar groove. Tennis elbow is actually on the outside part here. And it has to do with where all the wrist extensors that bring your wrist up, or finger extensors that bring your fingers up, they all attach to this one bone on the outside of the elbow, the lateral epicondyle. Tennis players get this inflamed, particularly if you're doing a one-handed backhand and you have really tightly strung racket. There's a lot of force that goes on these muscles that are bringing your wrist back. And that causes inflammation of the attachment there. And so what you generally do is treat it with conservative measures, ice. You may want to use local topical anti-inflammatories like Dr. Sandhu was saying. You want to work on your range of motion and your strengthening. And that does generally improve if you can work on those kinds of things. Tiffany, how about exercises for fine finger movements?
So I did mention using putty. Putty is a great tool to practice some of your fine finger movements. You can either grab some putty from the dollar store, or there's something called TheraPutty, which you can purchase from any medical equipment store. And so you can run through the different movements that your fingers do. So pinching, you can do, let's say, a log roll of the putty. Practice each pinch. And if the putty has some resistance, you're going to be practicing your strength and working on your strength. You can put them between your fingers and then crush them this way. So there's lots of exercises out there. Sometimes it takes a bit of know-how to know where to find it. If you have access to the internet, that is a good tool. Otherwise, sometimes you may have to find a local therapist in your community that can help direct you specifically in terms of what movements you should be doing with the putty.
Dr. Sandhu, what's your opinion about ibuprofen as a long-term anti-inflammatory? And if you take it, what organs are at risk?
Okay, so ibuprofen and naproxen, as I said, are probably safer from the cardiovascular perspective than some of the other anti-inflammatories. Really, with any sort of medication, when you're thinking about it, you're going to weigh up the benefits that you're getting from it with the side effects and the risks. So if you're using ibuprofen long-term, because you're not able to use anything else to allow you to function, then it might be worth the possible or potential side effects. And so you're always going to weigh those things up. But if I was picking an anti-inflammatory, I would usually use ibuprofen or naproxen just because they're slightly safer from the cardiovascular perspective. In terms of other things, with any anti-inflammatory really, you should take it with food unless it has unless there's a particular type of naproxen which is combined with a stomach protector, and it's called Vimovo. And in that situation, you should take that on an empty stomach, so the stomach protector works first. Otherwise, most anti-inflammatories should be taken with food to protect your stomach lining and try and prevent ulcers. And anti-inflammatories aren't that great in people who have kidney disease. So it would be something that I would watch with caution if there was any suggestion of kidney disease.
Can you just take them long-term, like forever?
Some people do end up taking them long-term. Usually the people who take it long-term are people with inflammatory arthritis, for example, like rheumatoid arthritis, and especially when there's been, because these patients have a lot of stiffness in the mornings. And for some people, even when you get rid of the inflammation with other disease-modifying drugs or biologic agents, there's still that significant stiffness, and the only thing that helps with that is the anti-inflammatory. And so sometimes you just have to weigh that risk with the benefits that you're getting to allow you to function.
Thank you. Dr. Binhammer, is nerve damage possible during carpal tunnel surgery?
Yes.
Okay.
The risk is less than 1%. It's very low.
Excellent. And while we've got the microphone, I know that the toe is not part of the hand. I still believe it's not part of the hand. But is there a structural similarity between trigger finger and hammer toe?
No. They're different problems.
Okay. Yeah, they are different problems. Question for me, what specialist should I get a referral to from my family doctor for increasingly debilitating diabetic neuropathy in the fingers? Good question. So it's diabetic neuropathy. In some people, they present mostly with numbness and tingling. It's not necessarily painful in everyone. In most people, it affects the feet first. And the really big issue there is protection of your feet. So if you want to avoid having a rock in your shoe that you don't know about because you don't feel it, having a sore in your foot that starts to develop and get worse. So it's really careful foot care. And you might go to a podiatrist, a chiropodist. You might go to a physiatrist, which is what I am, not a psychiatrist, physiatrist, or a neurologist. And the same thing for the hands. You might consider a physiatrist like myself or a neurologist. Many times your family doctor will be able to start you on some medications. There are some newer medications that are looking really good. There are medications that stabilize the nerve membranes, and the two big ones are Lyrica, or pregabalin, and gabapentin, and those are used quite well. And then I think Dr. Sandhu mentioned some of the antidepressant medications. We're not really using for depression, we're using them for other things to modulate the pain, and duloxetine is one of them that is used quite commonly. So there are some medications. Family doctors often have a good way to start that, and then a neurologist or a physiatrist can help. You don't want to get on opioids for this kind of thing. I think you probably all know that already. For Tiffany, I find massage therapy really helps me manage my osteoarthritis pain. Is it possible to get too much massage?
That's a difficult question. So in terms of relief from massage, I don't think there's too much in terms of osteoarthritis, unless you should definitely tell your massage therapist that you have arthritis in a joint so they can pay specific attention, not to go too deep, because you could have joint instability and they could re-aggravate it. But I'm assuming your massage therapist is probably working on the muscles around your joint to decrease some of that stiffness and rigidity. So maybe you're feeling some benefits from that. But do make sure to tell your massage therapist that you have osteoarthritis and in which joint so they can be aware.
Dr. Binhammer, in normal circumstances, how long does it take for inflamed tendons to heal? And Dr. Sandhu might have thoughts on this too.
I think it really depends upon the problem, but if you're talking about after trigger finger surgery, the tendon is still inflamed, you've taken away the problem, it takes about another 6 weeks for it to settle down. There are some other inflammatory tendinopathies. Probably one of the most common is called de Quervain's tenosynovitis. It happens on the side of your wrist over here. And usually, not always, but usually if somebody presents with that and they get into a splint, usually after 6 weeks, their tendinopathy has settled down.
I'd agree. I would usually say if you rest it, that 6 weeks is the ballpark.
And for these, like Descartes veins, which is a common one, the main thing is you want to prevent overuse of that thumb. And so it's a different type of splint to, and Tiffany may want to comment on this. It's not a splint just for the wrist, because the thing you want to really keep stable is the thumb. It's called a thumb spiker splint. So you want to let that thumb rest for a number of weeks so that that's immobile and just let those tendons heal. I don't know, Tiffany, do you want to talk about Descartes veins?
Depending on the therapist, sometimes the splint used for Descartes veins will include the wrist, so immobilizing the wrist, or maybe using it as a support system to get to the thumb, to let the thumb rest and immobilize the thumb. So that way your tendons, of course, can rest and adequately function better.
Dr. Sandhu, can you talk about glucosamine sulfate and possible pressure in the eye? Is there a connection between pressure in the eye? Then there's a reference to a Lancet article.
I'm not a particular fan of glucosamine, but I haven't actually read that article, so I'm going to have to pass on that one. Sorry.
Okay. Well, we got another backup question for you. Rituxan for rheumatoid arthritis.
Yep. So we do use rituximab. So for those of you who don't know, when we were talking about rheumatoid arthritis, and there've been, really in the last 20 years, treatment of rheumatoid arthritis has become revolutionized with the use of what we call biologic agents. So rituximab is a medication that targets B cells, which are a type of white cell that is upregulated in inflammatory arthritis like rheumatoid arthritis, and is also responsible for producing antibodies. It was initially used to treat lymphoma, but we are using it to treat rheumatoid arthritis as well as vasculitis. We don't tend to use it as first line, and really in rheumatoid arthritis, it's only useful generally in people who are what we term seropositive. So about 30% of people who have rheumatoid arthritis don't actually have, when we do the blood test, rheumatoid factor or another antibody called your anti-CCP antibody. And in those patients, it's not as helpful, but otherwise rituximab is often used. It's often used after we've tried other medications, more conventional medications like methotrexate, and usually after we've tried another type of biologic agent targeting different types of inflammatory proteins. A specific one is anti-TNF agents.
Thank you.
But it does work very well. It takes a little bit longer to work, but it does work well in a particular subset of patients.
Thank you. For Dr. Binhammer, at what stage of the Dupuytren contracture should you see a surgeon? When should you see a surgeon?
So there's a useful test, not necessarily, so you said see a surgeon as opposed to have surgery. So there's a useful test, and that is, which you can do at home, and that is you put your hand flat on a table. And and we call it the tabletop test, as long as you can get your hand reasonably flat, if you go to see a surgeon, he's going to tell you there's nothing that I would advocate doing for you. When you start to have problems getting your hand flat, then you can have a discussion with the surgeon about what are the treatments, what are the advantages and disadvantages in my particular situation.
Okay, thank you. I have a question for, is laser therapy helpful for arthritis and pain? I'll give you my answer, and those of you who are familiar with this may have a different answer. So pain in arthritis, there's a number of approaches to reduce the pain in arthritis, and some of them are medications to try to reduce the inflammation and the process that's causing the arthritis. Some of them are surgical, some of them are therapy to avoid overuse and inflammation of the joints, and some of them are focused on pain relief primarily. And I kind of think about laser therapy in that pain relief category. So laser may be useful. Acupuncture, some people find useful. Heat and cold can be useful. Those would reduce the pain. They won't necessarily change the course of the disease very much, but they're still useful. I mean, just because it doesn't change the course of the disease, if you find it reduces your pain, it can be useful. Unlikely to cause any harm unless you're looking in the laser, but unlikely to cause any harm, and it may be useful for pain reduction. Dr. Sandhu or Tiffany, any? Okay. Plaquenil is no longer advised, as you said. What are the alternatives?
So Plaquenil is no longer advised for nodal osteoarthritis. And so the alternatives go back to what we talked about in terms of the topical anti-inflammatories, all the non-pharmacological modalities that we talked about as well in terms of the adaptive devices and splints. But from a pharmacological perspective, really topical anti-inflammatories, oral anti-inflammatories, and oral acetaminophen tend to be the mainstays, plus minus pain modulators as needed. There are some side effects with Plaquenil, and we know that in a certain proportion of people, if you take them for too long, they can cause trouble with the retina. And in a very, very low minority of people, sometimes it can also cause cardiomyopathy. So if you know that it's not going to, if the studies show that it really doesn't provide any benefit, then there's no point being exposed to the risk of it.
Great, thank you. Dr. Binhammer, if someone had a right trigger thumb and the nodule restricts movements and has had 2 failed cortisone shots, are there any other non-surgical treatment options?
So they can try rest and through perhaps a splint. The problem with splinting is it can lead to stiffness. So those would be, you just have to be careful. Otherwise, that's it.
Okay. Tiffany or Sharron, any other treatment options?
I guess other modalities you could try in terms of seeing a therapist, and again, using hot and cold, hot to maybe help to expedite the range, to help with the range if you're having some decrease in movement there, and just going gentle but with the rush, just also doing some movements.
Great, thank you. And one more surgical question, and then we're, I think, going to be out of time. What is the recovery rate of finger movement after synovectomy and tendon transfer surgery? You know, that may be too specific to answer.
Or not specific enough.
Yeah.
So synovectomy and tendon transfer are really sort of 2 different operations, occasionally combined for patients who have rheumatoid arthritis and who might have a tendon rupture. So if somebody's had a tendon rupture, and probably the most common would be an extensor tendon rupture in a patient with rheumatoid arthritis, and we do a synovectomy and we transfer some of the tendons because initially they won't be able to extend their small and perhaps their ring finger. So we move some of the tendons around from where people have duplicates. So that's how we can do tendon transfers, is sometimes you have 2 tendons that do one function, so we can steal them to do a different function. So we're going to transfer a tendon, say if you have 2 to extend your index finger, we can move it over to help your small finger that might have ruptured. And if you have that surgery done, that usually total recovery is about 3 months, but back to sort of activities of daily living without your splint is around 6 weeks.
Thank you. I'm afraid we need to wrap up now. We're very careful about everyone's time. I think there may be a few minutes that you can come up and ask the speakers or additional questions. Just a few points before we wrap up for the evening. Now, recognize the importance of learning from our patients. We actually have a weekly blog. It's called the Personal Health Navigator, and it's written by Paul Taylor, our navigator at Sunnybrook, and published on our website. The blog provides advice to patients about navigating Canada's healthcare system, relying heavily on medical and health experts. And you can send your questions to Ask Paul, not this Dr. Paul Binhammer, but Paul Taylor, and he can help figure out what the answers may be. Be sure to hand in your completed evaluations tonight, because we really take these seriously. So hand them in and wait and pick up a free parking voucher. If you have trouble finding the box that says excellent or outstanding, let one of us know. We'll point you to it. A special thank you to our volunteers and all the groups outside the auditorium tonight, and a special thank you to our panel of excellent speakers. They'll be available for just a few minutes at the front of the room if you have additional questions. We do have the Sunnybrook website, www.sunnybrook.ca. Please look at that for upcoming lecture topics and dates. And thank you again for spending your Tuesday evening with us. Have a good night.